Good evening. Thank you for joining me today. My name is Michael Hartle, and I'll be presenting my research proposal on comparing the efficacy of kettlebell resistance training versus aerobic training in adults with type 2 diabetes. This study aims to determine which exercise modality provides superior outcomes for this population. Type 2 diabetes, otherwise known as T2D, has reached epidemic proportions globally. Exercise is firmly established as a fundamental component of diabetes management, with robust evidence supporting its effectiveness for improving glycemic control. While aerobic activities such as walking and cycling have traditionally been a standard recommendation for people with diabetes, growing research indicates resistance training may provide distinct benefits. Kettlebell training represents a particularly promising modality as it integrates elements of both resistance and cardiovascular exercise within functional movement patterns. For context, type 2 diabetes involves insulin resistance and disrupted glucose metabolism. Physical activity directly enhances insulin sensitivity and glycemic control, hemoglobin A1C, through several physiological pathways. Historically, aerobic exercise has been the primary recommendation for people with diabetes, backed by substantial evidence demonstrating its effectiveness. However, resistance training has received increasing recognition in recent years, with emerging research indicating it may be equally beneficial or potentially more effective for certain outcomes. Kettlebell training offers a distinctive approach to resistance exercise, featuring dynamic, full-body movements that activate multiple muscle groups simultaneously. What makes kettlebell training particularly valuable for diabetes management is its combination of strength and cardiovascular benefits in a time-efficient format. The ballistic nature of kettlebell exercises builds muscle mass while generating significant metabolic demands. This dual-action mechanism may be especially advantageous for glycemic control. Furthermore, the functional character of kettlebell exercise can improve exercise enjoyment and promote long-term adherence. The significance of this study lies in addressing a critical gap in current diabetes management. Despite growing evidence supporting resistance training, existing guidelines primarily emphasize aerobic exercise for people with diabetes. Research specifically examining kettlebell training in the T2D population remains notably limited. This is significant because kettlebell training offers potential advantages particularly relevant for diabetes management, including increased muscle mass, a key tissue for glucose metabolism, enhanced functional capacity for daily activities, and potentially improved exercise adherence over the long term. The significance of this research problem is profound. According to the CDC, 38.4 million Americans have diabetes, with T2D representing over 90% of cases. An additional 97.6 million adults have prediabetes, placing them at elevated risk for developing a disease. The economic impact is equally enormous, with diabetes costing the United States approximately $327 billion annually in direct medical expenses and decreased productivity. There is a pressing need for effective exercise interventions to improve clinical outcomes and quality of life for this expanding population. A review of relevant literature reveals that aerobic exercise typically improves hemoglobin A1C by 0.5 to 0.7%, a clinically significant finding firmly established by Umpierre's 2011 meta-analysis in the Journal of American Medical Association. Notably, resistance training demonstrates comparable improvements in glycemic control according to Ishiguro's 2016 meta-analysis. Even more compelling, Kohlberg and colleagues' 2016 American Diabetes Association position statement suggests combined training may provide additive benefits. Hong's 2017 cohort study showed muscle mass is inversely associated with insulin resistance, illuminating the potential mechanism behind resistance training's glycemic control benefits. Despite these advantages, exercise adherence remains a significant challenge across all diabetes management modalities. Benham's 2020 study identified a dose-response relationship between exercise adherence and hemoglobin A1C improvement for aerobic and combined training, but not for resistance exercise alone. Greater volumes of aerobic or combined exercise were associated with improved glycemic control. This leads us to the gap in the literature that our study addresses. Research directly comparing kettlebell training to aerobic exercise in people with T2D remains limited. We simply do not know whether kettlebell training delivers superior glycemic control, exercise adherence, or functional outcomes compared to traditional aerobic exercise. Furthermore, while the relationship between muscle mass and insulin sensitivity is established generally, a specific connection between muscle mass changes and glycemic improvements resulting from kettlebell training needs further investigation. There exists a clear need for evidence-based alternative exercise modalities that can be recommended to individuals with diabetes. The purpose of this study has 4 components. First, we aim to compare how kettlebell training versus aerobic training affects glycemic control in adults with T2D. Second, we will investigate the relationship between lean muscle mass changes and hemoglobin A1C to better understand the mechanisms behind any observed improvements. Third, we will evaluate differences in exercise adherence between the 2 modalities and recognize that even the most effective exercise is only beneficial if consistently performed. Finally, we will assess functional capacity improvements from both exercise approaches to determine which better translates to enhanced ability to perform daily activities. Our study is guided by 2 primary research questions. First, among adults with type 2 diabetes aged 40 to 70, how do 12 weeks of kettlebell exercise compare to aerobic training, improving glycemic control, exercise adherence, and functional capacity? Second, in the same population, to what extent do changes in lean muscle mass as measured by DEXA scanning generate improvements in hemoglobin A1C following a 12-week kettlebell training program compared to an aerobic exercise control group? These questions will help us determine not only which approach is more effective, but also the mechanism behind any differences. We have formulated 3 directional hypotheses based on existing literature and theoretical mechanisms. First, we hypothesize that 12 weeks of kettlebell resistance training will yield greater improvements in hemoglobin A1C compared to aerobic training. Second, we predict that lean muscle mass changes following kettlebell training will correlate more significantly with hemoglobin A1C improvements, demonstrating a stronger relationship than changes observed in the aerobic training group. Finally, we hypothesize that kettlebell training will show higher exercise adherence rates than aerobic training throughout the 12-week intervention program period, potentially due to greater exercise variety and perceived enjoyment. Theoretical framework. This study combines social cognitive theory, SCT, and systems theory because SCT addresses the behavioral aspects of exercise adherence through self-efficacy, mechanism-wise systems theory provides a physiological framework explaining how kettlebell training specifically affects glucose metabolism and insulin sensitivity pathways in type 2 diabetes management. These include increased GLUT4 translocation to the cell membrane, which enhances glucose uptake, enhanced insulin signaling pathways, improved mitochondrial function for greater metabolic capacity, and increased glycogen storage capacity in skeletal muscle. Additionally, we consider psychological factors in exercise adherence, including self-efficacy, perceived confidence, and enjoyment, which may differ between exercise modalities and influence long-term outcomes. Our study will employ a parallel group randomized controlled trial design. We will recruit 40 adults with type 2 diabetes aged 40 to 70 years and randomly assign them to either kettlebell resistance training or aerobic training for 12 weeks. The kettlebell group will have 20 participants, as will the aerobic training group. To ensure baseline equivalence between the intervention groups, we will implement stratified randomization using prognostic factors, including distinct groups of hemoglobin A1C levels, age categories, BMI classifications, and diabetes duration. To track changes over time, we will conduct assessments at baseline at the midpoint 6 weeks to look for any acute changes, and post-intervention 12 weeks. This design allows us to make direct comparisons between interventions while controlling for confounding variables. Our study population will consist of 40 adults aged 40 to 70 years with T2D recruited from Allen County, Indiana. To ensure appropriate selection, we have established specific inclusion criteria, which includes hemoglobin A1C levels between 6.5 and 11%, indicating diabetes that is not optimally controlled but not severe enough to preclude exercise participation. Participants must also have a sedentary lifestyle defined as no structured exercise in the previous 6 months to allow us to observe the full effect of introducing regular physical activity. Our exclusion criteria are as follows. We want to do it designed to ensure participant safety, excluding individuals with blood pressure exceeding 160 over 100 millimeters of mercury, insulin pump users, those with a history of stroke, advanced neuropathy or retinopathy, or any other medical conditions that would make exercise participation unsafe. We will implement comprehensive outcome measures to address our research questions. Our primary outcome for glycemic control will be hemoglobin A1C measured using the DCA 2000 plus analyzer, which delivers reliable results from a simple finger prick sample. This testing is made possible through external financial support. Exercise adherence will be monitored through direct observation during supervised sessions and detailed workout records. Functional capacity will be evaluated through a test battery, including the 6-minute walk test, timed up and go test, 5 times sit to stand test, and hand grip strength test, providing a comprehensive assessment of participants' physical capabilities. DEXA scanning offers precise compartmental body composition data, which will be used to measure body composition, particularly lean muscle mass. Finally, the validated diabetes self-management questionnaire will assess self-management behaviors. The kettlebell resistance training intervention will consist of 3 sessions per week for 12 weeks. Each session will follow a circuit format focusing on 2 primary movements selected for their effectiveness and accessibility for our population. Kettlebell swing will be performed for 10 repetitions and a 12 repetition max, with 2 repetitions in reserve to ensure safety. The get-up, a more complex movement that develops whole body coordination and strength, will be performed for 1 repetition per side and a 3 repetition max, again with 2 repetitions in reserve. We will progressively increase volume from 2 sets to 4 sets over the program duration, with 1-minute rest intervals between sets. Weight progression will occur in 2 kilogram increments when participants can execute more than a designated repetitions with perfect technique and report a rate of perceived exertion below 8 out of 10. Certified kettlebell instructors will supervise all sessions to ensure proper technique and safety. The aerobic training intervention will also consist of 3 sessions per week for 12 weeks. Participants will perform walking exercise either outdoors or on a treadmill, depending on weather conditions and participant preference, starting at 20 minutes per session and gradually increasing to 30 minutes per session. We will progressively increase intensity over the 12 weeks, reaching 70-75% of maximal heart rate by the end of the intervention. To ensure accurate intensity monitoring, participants will use GPS-enabled heart rate monitors that provide real-time feedback. Additionally, we will use the RPE scale, keeping below an 8 out of 10. Like the kettlebell group, exercise specialists will supervise all sessions to ensure proper technique, appropriate intensity, and participant safety. Our data analysis will follow the intention to treat principle to preserve randomization integrity. We will utilize paired t-tests to assess pre-post changes within each intervention group and independent t-tests to compare differences between groups. To address potential confounding variables, we will employ ANCOVA with covariates including baseline values, gender, age, race, ethnicity, and diabetes duration. Pearson correlations will examine the relationship between muscle mass changes and hemoglobin A1C improvements, addressing our second research question. All analysis will be conducted using SPSS Statistics 29, with statistical significance established at p is less than or equal to 0.05, enabling us to draw meaningful conclusions about the comparative effectiveness of these interventions. Limitations and contributions. We acknowledge several potential limitations in our study. As a single-center investigation, relatively short 12-week intervention period, the generalizability and long-term effects may be restricted. Furthermore, the nature of exercise interventions prevents blinding participants to their assigned protocol, potentially introducing bias. Despite these limitations, our study will make significant contributions to the field. It will provide evidence for optimal exercise prescription and T2D, offer mechanistic insights into exercise-induced glycemic improvements, and generate practical recommendations for clinical practice. Additionally, it will establish groundwork for larger extended studies and examining sustainability and long-term outcomes of different exercise modalities for diabetes management. These references represent the key literature that informs our study design and hypothesis. Collectively, they demonstrate the established benefits of both aerobic and resistance training for type 2 diabetes, while highlighting the need for direct comparison between specific modalities like kettlebell training and aerobic exercise. Thank you for your attention, and I appreciate your time.